So this brief talk is about the left main assessment, and there will a couple of slides about the treatment of left main, and it's mostly geared for the junior fellows. So left main is an important artery, needless to say, supplies 85% of the heart in the right dominant, in the major population. If you're right dominant, your left main supplies 85% of the heart. Nobody essentially survive uh, left main occlusion, sudden occlusion. The having a left main disease as a poor prognosis, having a significant left main disease carries a very high mortality. About two-thirds of these patients die in about 3 years. There has been very little, but nonetheless, given evidence that revascularization of that left main will improve the mortality. And since then, that's been taken as a standard of therapy. In terms of if you look at the histology, couple of things. Obviously, the location could be ostial or mid or distal, and those carry significant implication in terms of therapeutic. The IVUS, interesting, showed that these lesions in the left main behave more like aortic lesion rather than coronary lesion. They don't rupture as much as the other coronaries. The lesion itself have thick cap, have stable core, not much of a necrosis in this. So that's may explain some of the fact we don't see a lot of ruptured left main. You see it once in a while, but you don't see rupture and thrombosis of the left main. Again, we see some of this once in a while. Now, why we all say 50% is significant at the left main, while when we go to the sub branches we always say it's 70 or 80%. That's a hemodynamic significant. Well, this stems from a couple of sources. One, animal disease. You tie the left main and you decrease the tying, and until you find compromise in the distal flow in the arteries, and it turned to be from the animal models. It's the 50% cutoff appears to be where the hemodynamic significance become an issue. It's particularly hard in the left main by angiography to say it's a 50%, 60%, or 40% or so for multiple reasons. Sometimes the left main is so short that you don't have reference vessel to compare the stenosis to the normal segment. Obviously, a larger problem with angiography is remodeling of the arteries. The distal left main, there always be overlapping. Most of the angle that the circ and the LAD comes off, they're overlapping at that side. But that's why you never see really clear-cut involvement of the disease in the ostial of these two vessels, but it's always there. That's why some other modality in the left main will be necessary. Other problem in the left main, it has this reverse tapering. Normally, the vessels tapers from the proximal to distal. The distal tapers and becomes smaller. The left main, sometimes there's the opposite phenomena where the tapering starts proximal to distal, like similar case. And I would mention this case that's been circulated in national meeting, and it comes from the suburb of Philadelphia. It's a 45 years old lawyer with no risk factors that was admitted with the hospital with chest pain. Catheterization showed ostial left main, as you see here. and you also see there's the sternal wire. So obviously he underwent bypass surgery with two vessel bypass. The post-op course uneventful, recurrent chest pain 1 month later. Repeated angiography at that point showed occlusion of the grafts, but the native anatomy is still the same with what looked to be significant left main. Referred for repeat bypass, again had survived the next second surgery and presented again about a month later with chest pain. Repeated angiography showed closure of the second set of the grafts with the lesion at the distal anastomosis where one of the grafts attached. And finally, it was decided to IVUS that left main. And this is the IVUS of the left main, have no disease whatsoever in the ostium. And that's the reason why the grafts closed. So this kind of story is like a caution about to the assessment of the left main and how deceptive it could be by angiography only. So the disease most commonly is in the distal vessel, and almost always, as we mentioned earlier, involve the takeoff of two vessel, although angiographically it's not apparent, but almost always involved. The reason is by histology. If you look here, the carina of the distal left main here and here is always spared. The distal left main does not affect the carina, but affect the vessel in the left main that obviously lesion extend into the LAD here, and in the circ extending into the ostium of the circ. So carina is spared. It's involving both ostium almost always. So this is an important factor. All right. So you see us assessing all the lesions by FFR wire, simple test, reliable, most of the time reproducible. There's good evidence at this point that FFR is a good test. So why don't we do this here and decide about the significance of the left main? Okay, well that's appears to be reasonable. There's significant evidence support that physiologic assessment, the FAME2 trials. The principle of FFR by essentially measuring the flow of the vessel before and after lesion should apply to the left main also. The problem with that this disease has been excluded from all these trials. The data that support the left main FFR is come from smaller trial, but there are some evidence that having an adequate or normal FFR in the left main, it make it safer to defer revascularization. That you don't have to rush the patient. Some of the studies, this is a crowded slide, that there is a lot of looks of smaller trial about the FFR. The only thing, a common thing with this in terms of the clinical endpoint, revascularization was higher in the excuse me, in the FFR positive group. Otherwise, the hard endpoint were not significant. And here's the reason why. If you look at the upper graph here, the drawing, there is a lesion in the left main, and you want to FFR it. We just mentioned that the association between the left main disease and the other branches, the LAD and the SERD, is very, very common. It probably happen in about 3/4 of the cases or more. And you put the FFR wire, you measure the pressure before and after you measure it here and you measure it here, and you see the FFR of the ostial segment of the LAD comes 0.84. But you look at the angiogram, there's another lesion here, and you measure FFR at this level, you see it is also significant. But if you go ahead and stent the LAD here and put stent, open that, the FFR in the LAD itself here becomes significant. I'm sorry, here in the FFR where is a lesion in the LAD, the FFR was not significant, 0.84. Where when you stent that lesion in the LAD, the FFR become positive. So the assessment of the left main with the FFR is fairly difficult, especially with apparent disease involving the sub branches. And if I have to FFR it, you have to go to the two vascular bed. Sometimes there's more than two vascular bed, and sometimes if the RCA is occluded and the left main giving collateral will intervene. So the FFR has been problematic in the assessment of the left main, and you probably cannot base your decision about surgery based only on the FFR. Having said all that, last month in JACC, an important trial actually using the IFR. For all practical purposes, IFR and FFR are interchangeable. I mean, the data that apply to the FFR do apply to the IFR. The IFR has two larger studies than the FFR, so it's been becoming quickly the standard tool for physiologic assessment for us. It's the practical different. FFR you have to give vasodilator. The IFFR does not, but that's a topic for another story. The normal cutoff of the IFR is 0.91. But here they went a little lower, so they divide the two subgroup over 300 patients for IFR more than 8.89 or lower than 8.9, and they base the revascularization therapy based on the IFR completely, and making that decision, they looked into the two subgroup and they followed that for more than 50 months, and they both did very well, concluding from the trial that IFR of 0.89 is a very good tool to assess the left main disease. Problem with this trial, although it's very important, it does add a little bit of data for us of the FFR IFR assessment. They excluded about 100 patients where the attending physician, clinical or interventional cardiology, overruled the decision by sending the patient to surgery or deferring the surgery. So out of 400, there was 100 patients that were excluded, which make the trial, again, questionable at this point. More important trial to be aware of the assessment of the left main is the IVAS trial. It's a Spanish trial performed in Spain. It's called the LITRO trial. Has been the standard for our assessment. The number to remember in terms of the left main assessment is 6 square millimeter. That's the MLA, minimal luminal area, of 6 millimeter. That 6 millimeter did not just picked out a hat. It's evolved over years and studies. Initial recommendation were 9 millimeter, and then we went to 7 millimeter, 8 millimeter, and finally the 6 millimeter. It seems like there is a cutoff there. So this trial took 350 patients, divide them in both. One have MLA. Those are all intermediate left main disease. MLA less than 6 meter, MLA more than 6 millimeter. And the MLAs less than 6 millimeter, these are the sick patient. The majority end up having revascularization, some with surgery, some with stenting. But there was a 16 patient out of this where they did not have surgery for one reason or another. And this is the group where actually the recommendation come from. And the MLA more than 6 millimeter, they were mostly treated medically. Sorry. And here's the result of this. If you look at the right side, the left side, excuse me, where uh, the upper panel and the lower panel looking on these patients, the one deferred group and the revascularization group, based only on the MLA, both group did very well. If you follow that protocol, you do very well. What about those 16 patients? That's the lower left panel. Those 16 patients that have MLA less than 6 millimeter and did not go for surgery. Comparing with the patient that have MLA less than 6 millimeter and have surgery, there was a significant difference in this group in terms of the outcome. So and those people they less than 6 millimeter but over 5 millimeter. So that's why we feel that 6 millimeter is probably the reasonable cutoff for IVUS. Going below the 5 millimeter, it probably will not add any advantage. So that's why it became the standard of therapy of measuring a simple measurement, very objective, the minimal luminal area at any point of the left main that will guide the therapy. There's no specific guideline, American guideline in terms of usage of the IVUS. There is some European guideline. Obviously, FFR is also exist in both guideline, American and European. FFR is a very important tool to be used in identifying physiologically important stenosis and multivessel, single vessel. Left main IVUS, it's a 2A recommendation to be basis of therapeutic recommendation. Literally 3 slides on the treatment of left main. Since the advent of modern PCI, cabbage versus PCI of the left main, multiple studies have not shown survival difference overall between, I shouldn't say survival, there's no difference in the endpoint between left main and surgery and PCI. 3 studies to be aware of. The syntax trial had proven over years and years that to be very, very helpful trial for all our decision making. A simple anatomic classification of the patient disease will show you this is the overall cohort of the patient. If your syntax is low or medium, the numbers here is 0 to 22 is more low syntax score, 22 to 32 medium score, and the high score is over 32. So if you take the low and medium in the upper panel, you see the survival is the same. If you take the individual endpoint, most of the differences happens in the revascularization as well as the stroke evidence. The stroke favors PCI, but revascularization obviously favor surgery. 2 modern trial you need to be aware of and left main treatment. One called the Noble from Scandinavia, and the other called Excel. It's an American trial. And these 2 trial, one is positive, one is negative. The Noble was negative trial, favored significant advantage to cabbage in overall cohort of left main disease. The Excel trial, there was no significant difference between the two groups. Where this leave us, the guideline still heavily favors surgery for left main disease. If you treat the patient for survival benefit, cabbage is the only proven method to improve survival in a left main disease of a 50% or more. PCI, the reasonable 2A alternative to cabbage in high risk surgery. Uh, so PCI should not be performed to improve only survival. We do have now a whole big group of patients that are the surgical turn down, and we end up doing something to them, and that you're not doing this to improve their survival. You're really doing this to improve their symptoms by intervening on this cohort of patient of distal and complicated left main. Uh, Bottom line, the two guidelines slightly differ in terms of the recommendation. So bypass is class 1 in all cohort of left main disease, lower syntax, medium syntax, high syntax. Surgery is the preferred therapy, class 1. In low syntax score, it's 2A, medium 2B, and it's a 3 in the high syntax score. The European guideline gives the low syntax score class 1 for PCI. So, in summary, that the treatment is really depends on associated disease, clinical status of disease, but the treatment is surgery with PCI, probably a low second choice.